Hello everyone, my name is Muhammad Yassin. Today I'm going to present about multiple sclerosis. First, what's multiple sclerosis? Multiple sclerosis is progressive immunological mediated disorder of the central nervous system that eventually result in increased cognitive and physical impairments. The hallmark of multiple sclerosis include demyelination, axonal loss, and neuroinflammation, resulting in localized lesion called plaque in the optic nerve, spinal cord, and the brain. Astrocytes create genetic plaque, which form of scarring that block axonal transmission as a consequence of injury because oligodendrocytes lose their ability to replace the myelin. Type of multiple sclerosis. Multiple sclerosis categorized primary by clinical patterns to remitting relapse multiple sclerosis and progressive multiple sclerosis. The relapse remitting multiple sclerosis, which is account about 85%, and the patient actually swing between relapse and remission status. While the progressive, the patient get worse over the time, and there's two type of progressive. The first one is primary progressive, and the second one is secondary progressive, which is developed from relapse remitting multiple sclerosis. Global prevalence and demographic. There's actually about 2.8 million patients around the world. Higher prevalence in North America and Northern Europe. In addition, female affected 2 to 3 times more than male due to hormonal and genetic factor. Pathophysiology of multiple sclerosis. First, we have the immunopathology in the peripheral immune system, where the autoreactive T helper cell 1 and T helper cell 17 escape immunity tolerance, then activate T cell proliferation and migrate through the blood stream, cross the blood-brain barrier into the central nervous system. In the CNS, they release pro-inflammatory cytokines that activate microglia and macrophages, triggering sustained inflammatory response. This immune cell attack myelin sheath surrounding the axon, causing demyelination, impair nerve conduction, and axonal damage. And in addition to this dysfunction of T regulatory cell fail to suppress the autoimmune response, allowing to chronic inflammation and progressive neurodegeneration. This is the mechanism of immune deregulation. We have also the smoking. Smoking accelerates the onset and progression and relapse risk for multiple sclerosis by increasing the oxidative stress, pro-inflammatory cytokines, immune dysregulation, in addition to release toxic chemical which damage the oligodendrocyte, lead to demyelination, axonal injury, and chronic inflammation. And this is the effect of smoking and how it triggers to multiple sclerosis. We have also vitamin D deficiency. Vitamin D deficiency reduce T regulatory cell. As a result, it increased the T helper cell 1 and T helper cell 17 inflammatory response, leading to higher cytokines, interleukin 6 and interleukin 17 production, which promote autoimmune inflammation, demyelination, and greater risk for relapse. This is how vitamin D affect on the multiple sclerosis. We have also Epstein-Barr, which considers the strongest environment risk for multiple sclerosis by increase about 32 fold, especially in people who infected before with mononucleosis or have genetic variants in human lymphocyte DRB1. In addition, the immune cell mistakenly attack myelin after recognized the viral protein Epstein-Barr nuclear antigen 1 disactivate autoreactive the T and B cell. In addition to that, the latent viral latency viral in the B memorial cell, periodic reactivation, genetic susceptibility, and impaired immune regulation contribute to persistent inflammation and increase MS, multiple sclerosis susceptibility. We discussed before the genetic, which is highlight human lymphocyte antigen DRP1. There's also over 200 non-human lymphocyte antigen, which involve in immunity regulation, antiviral defense, and central nervous system integrity. Highlight the interaction between genetic predisposition and environmental triggers such as Epstein infection. Epigenetic also affect in multiple sclerosis and play a key role, especially microRNA 155 and 326. They contribute to immunity dysfunction, impair remyelination, and disease progression. Moreover, X chromosome epigenetic regulation may explain why female get or had high prevalence of multiple sclerosis. Diagnosis, mainly the diagnosis depend on the McDonald criteria, which the key concept of it dissemination in space, dissemination in time. Diagnosis require for fulfilling a specific criteria based on clinical attacks, MRI findings, and cerebrospinal fluid analysis. Clinical diagnosis, multiple sclerosis diagnosis based on medical history, neurological examination, evidence of lesion dissemination in space, dissemination in time according to McDonald criteria, MRI findings, and laboratory investigation. Common site of demyelination, we have periventricular white matter, optic nerves, brainstem, cerebellum, and spinal cord. The clinical presentation and symptoms usually develop over several days or last more than 24 hours in relapse remitting. Common symptoms include optic neuritis, unilateral vision loss, eye pain, and reduced color vision, limb weakness, sensory disturbance, myelitis, spasticity, and gait impairment, which is abnormal movement in the body, diploma, vertigo, bilateral intranuclear ophthalmoplegia, and fatigue. Image diagnosis, we have MRI, which is the gold standard for diagnosis and monitoring multiple sclerosis. We have also T2 weighted flare and post-contract T1 MRI, which help to detect demyelination lesion and active inflammation. We have diffuse tensor image, detect early matter microstructure damage. And for the optic nerve damage, we have optical coherence tomography. Biomarker for multiple sclerosis, we have the standard biomarker, which is cerebrospinal fluid and oligoclonal bands indicate the chronic intrathecal inflammation and support multiple sclerosis diagnosis. We have a neurofilament light chain markers of axonal damage and disease activity. Emerging biomarkers such as cell-free DNA reflect central nervous system tissue damage. We have microRNA regulate the immune response and remyelination. We have also GFAP, which is marker for astrocyte activation. We have YKL40, marker for neuroinflammation and glial activation. Multi-omics biomarker may improve the personalized diagnosis and treatment monitoring. Now we are going to talk about standard therapy and disease modifying treatments. The first line, we have injectable or oral, such as interferon, dimethyl fumarate, and triflunomide. Moreover, we have also high efficient agents such as ocrelizumab and natalizumab. For the acute relapse, we have corticosteroid. However, due to their metabolic and bone side effect, their long-term use is limited. Emergent therapies such as proton tyrosine kinase inhibitors. We have evobrutinib, fenebrutinib, and tolebrutinib, and I guess tolebrutinib now got the approval from EMA to treat relapse multiple sclerosis. We have also advanced therapy that still under investigation, such as CD4L inhibitors. We had BTD 802, which is promote oligodendrocyte precursor cell develop and enhance remyelination. Epigenetic drugs such as HDA C3 inhibitors and decitabine shift microglial and reset the immunity. Moreover, we have CAR-T and T-cell engagers, and also we have autologous hemobiotic stem cell transplant. At the end, the significant diversity of multiple sclerosis present a challenge for treatments to effectively manage symptoms, slow disease progression, and disease long-term relapse rates. Highly personalized therapy are necessary due to heterogeneity and clinical difference in clinical symptoms. However, emergent therapies such as proton tyrosine kinase and CAR-T therapy, T-cell engager, and autologous hemobiotic stem cell transplantation offer promising and precision medical option. This approach holds potential and more effective influence disease trajectory and target core immunological factor involved in complex multiple sclerosis developments. And if you have any question, don't hesitate to send to my email, and here our reference. Thank you for watching.